Good afternoon or morning, whichever you happen to be viewing this on. We're going to be doing our neurology section. We're going to be talking about intracranial pressure. First, I want to discuss a couple things. My name is James Reel. I'm the Chief Flight Medic at Apollo MedFlight, and I've been here since 2011. I've done a lot of education, set up a lot of the education program, and Ducey's doing a fine job, or Matt Adams, I should say. He's doing a fine job of carrying that torch and moving it forward. Today we're going to be talking about intracranial pressure, some neurology, some things that you need to know for working in the critical care environment. That's a little different than what you've learned in the field if you're a paramedic, or might be a little more than you've learned even working in an emergency department as an RN, depending on where you've worked and what you've had to deal with. We transport a lot of critically ill patients, and of course the head injured or closed head injury or a stroke patient is can be a very difficult patient to deal with, as they can run the gambit of having intracranial pressure problems that could lead to altermentation, which leads, of course, to intubation and invasive procedures. And some of these patients, as the pressure increases and they herniate, you can also see some cardiac changes and V-tach and V-fib cardiac arrest associated with this as well. So these are typically very sick patients that require quite a bit of monitoring. Most of the drugs that we give require or should have an ART line in place, and at times they have intracranial pressure monitoring as well. We'll be looking at today is number 215 in your protocol for increased intracranial pressure. That's going to be one of the ones I reference occasionally. Our protocol versus the presentation, there is one minor detail that I need to clarify. In this presentation, I use mean arterial pressure more than blood pressure, the lower side of systolic blood pressure, which in the protocol it will use. But really, the mean arterial pressure is better at maintaining cerebral perfusion. So with that said, we're going to get into this discussion, or this lecture, excuse me. And Homer Simpson, of course, has a small brain there. It's kind of a ha-ha moment. Anyway, the objectives that we're going to be looking for today are identify the anatomy of the brain and its significance to intracranial pressure, describe the factors that lead to increased intracranial pressure, calculate cerebral perfusion pressure, and identify the clinical indications for ICP monitoring, describe the 3 types of ICP monitoring, discuss interventions for decreasing ICP, and analyze the type ICP waveform and its significance. The waveform is very similar to what we would utilize for arterial line monitoring. So, the cerebrum has 4 lobes: frontal, temporal, and parietal and occipital. It's divided, of course, into 2 hemispheres. Conscious acts and motor thought and sensory output comes from frontal. Your midbrain visual and auditory and voluntary motor, and your consciousness, your pons, of course, which is there in just below the fourth ventricle, as motor control connects your cerebellum to the brainstem, and your medulla oblongata relay between the brain and the spinal cord, and your cerebellum is your balance and your gait. This is all stuff that should be rehashed for everybody. Of course, your meningeal layers, you got your dura mater, right? And there's another name for dura mater. It's called the tough mudder or tough mother. Your the arachnoid matter is actually non-vascular. In your subarachnoid below, if you look, looks like a little spider web in between there. This is highly vascular and covers the brain. The PIA continues the formation of CSF and supports your blood supply. Let's get into the vessels a little bit. Your arteries, carotid, vertebral, basilar, and circular willis, venous side, cerebral veins, venous sinuses, and of course your internal jugulars. Obviously, you can see on the PowerPoint the arch of the aorta going up into the vertebral artery and your carotids and your basilar artery, circular willis, and up into your middle cerebral artery. This is the venous side. Venous side is actually important for helping control intracranial pressure as well as the perfusion of the arterial side. Cerebral spinal fluid. Now let's back up one. I want to talk just a little bit about some of this stuff. There we go. So your right and left carotids supply the entire cerebellum, the 80% of your cerebral blood flow. Normal cerebral blood flow is between is about 750 milliliters a minute. Your vertebral form basilar artery comprises the posterior circulation, your cerebellum, brainstem, and base of the cerebrum, which is 20% of your cerebral blood flow. Let's see. An important thing that you need to realize about the venous side is that anytime the head is turned, you kink off your jugulars and can actually decrease the outflow from the brain case, from your cerebral circulation. Keep the head of the bed elevated 30 degrees for good continuous blood flow, and don't kink the neck. I mean, keep them in neutral inline position. The cerebral, got a little ahead of myself there. Cerebral spinal fluid, of course, bathes the brain and the spinal cord. 250 to 500 cc's produced every 24 hours. It's produced in the lateral ventricles of the brain. It removes waste, provides nutrients, and protects the brain. Actually allows it to float in there a little bit. When the cerebral spinal fluid pressure is greater than the venous pressure, the arachnoid villi drain into the nervous system. So the venous system is real important it does decrease ICP through this process. So something very key to remember. The ventricular system of the human brain, where the cerebral spinal fluid's stored and partially created. You have the left and right ventricle. You have the central part of the left lateral and right ventricle. You have the cerebral aqueduct, choroid plexus, and the central canal and fourth ventricle. And this is typically in the left or right ventricles where you want to cannulate to do invasive ICP monitoring. Let's talk a little bit about ICP. All right, so what is ICP? It's intracranial pressure, or intracerebral pressure. The normal is between 0 and 10, right? Bad would be greater than 20, and 40, greater than 40 is really, really bad. When the volume of any of the three cranial components, meaning brain tissue, blood, or CSF, increases, the volume of one or both of the others must decrease, or intracranial pressure will rise. So if the size of the brain tissue increases, or there's more blood than should be in there, or there's more CSF than should be in there, then it's going to increase the intracranial pressure. And one of those has to decrease, either the brain tissue, the blood, or the CSF. And if it's a big enough bleed and rapid enough, there isn't enough time for the CSF to regulate it and get it out. And of course, the buildup of that pressure leads to brain damage and or death and herniation. The Monroe-Kelly doctrine is when the volume of any of the three cranial components increases, the volume of one or both of the others must decrease, or their ICP will rise. Some causes of this could be anything from a mass effect, say space-occupying lesions, the drain isn't draining, obstruction or overproduction, hydro or hydrocephalus, bleeding in the brain, infections, head trauma, hypoxic or ischemic events. We all are aware of anoxic brain injury. The brain has the ability to auto-regulate by dilation, constriction of the blood vessels to shunt venous blood out of the skull, shunting CSF to the system and increasing absorption and decreasing production. But these are the things that interfere with it. These are the 4 H's. Okay, you've got hypoxia, PaO2 less than 80, hypocapnia, CO2 greater than 35, hypotension, mean arterial pressure less than 90, and hypovolemia. Those are the 4 things that can really complicate your day. Signs of intracranial pressure, of increased intracranial pressure. You have a change in LFC. This is your first sign. Headache, that can be a little bit argued on the headache, but typically it's going to be a change in LFC. Blurred vision, nausea and vomiting, pupillary changes in vital signs. Now, what changes, before we get to CPP, what changes in vital signs would you expect to see with increased intracranial pressure? There's a particular term, it's called Cushing's. It's decreased heart rate, decreased respiratory rate, and wide pulse pressure. These are late signs. They're not early signs, these are late signs. And fever, which is your hypothalamus getting squeezed down through the foramen magnum, increases, you lose the ability to control. Your hypothalamus stops controlling your temperature, so you have a temperature increase. Oops. Last mute. What is cerebral perfusion pressure? Well, it's the pressure that's required to provide oxygen and blood flow to the brain. So you're trying to protect the brain. And why is it important? Well, without it, your brain's going to be damaged, quite simply. You get anoxia through lack of blood flow and lack of nutrient delivery to the damaged brain tissue. And what are the effects of a traumatic injury? Well, the effects are that you've got an increase in tissue, blood, typically not CSF, but you've got increases in tissue size through injury, through swelling or direct injury. And then you have the blood that could be filling in the container because the brain doesn't give any, the skull doesn't give any, so it starts producing the pressure to push on the brain. And of course, we're talking specifically about the Monroe-Kelly doctrine right there. So you've got, as those increase, you have to have an opposing decrease, and the only decrease that could occur is with the CSF, and it's fairly slow. Of course, smooth perfusion is the goal. We want to keep the perfusion of the brain occurring without allowing more damage by giving it too much perfusion or more blood to fill in the space. So it's a pretty thin line we're walking there, but we have to keep cerebral perfusion pressure up to keep the brain protected and to provide oxygenation and nutrients to the brain. Cerebral perfusion range is usually 70 to 100 millimeters of mercury. To calculate the CPP, you need the following values. Obviously, you need the mean arterial pressure, which is 2 times the diastolic pressure plus the systolic pressure divided by 3. And then you have to have the ICP. And the only way to really get this is through invasive measurement. So it's your your cerebral perfusion pressure equals your MAP minus your ICP, okay? And we want that range between 70 and 100 millimeters of mercury. Treatments for intracranial pressure. Oh, one other thing. CPP less than 60 is hypoperfusion, and you want to maintain a MAP of greater than 90 with pressors or fluids when ICP is elevated, because the pressure of the brain actually can decrease the amount of or increase the amount of pressure that's required to provide the blood and oxygen and your nutrients to the brain. Treatment modalities, maintain your ABCs, keep ICP less than 20 millimeters of mercury, give volume to maintain pulmonary central venous pressure at 5 to 10 millimeters of mercury. Use vasopressors if needed to maintain a MAP greater than 90. And then determine the optimal CPP for that patient. Keep the brain temperature between 36 and 37 degrees. Remember, position the head of the bed no higher than 15 to 30 degrees in a neutral alignment. This is if they're not in shock. If they're in shock, you don't want to set them up, okay? You want to maintain your SATs, keep your CO2 to 35 or slightly less, and we'll talk about that because our protocol has a specific goal there. And hyperoxygenate prior to suctioning, because any hypoxic episode in these patients will lead to increased intracranial pressure. So I'm going to talk to you just a little bit about our protocol right here, because this is actually the treatment modality that's listed in our protocol. So, of course, your signs of intracranial pressure as listed in the protocol are heart rate less than 50, systolic blood pressure greater than 200, and diastolic greater than 110, decorticate or separate posturing, obviously, severe headache, abnormal respiratory pattern. This is where you could get central neurogenic hyperventilation or Shane-Stokes. Vomiting, altered sensorium, motor sensory changes or pupillary changes. And of course, if it gives us this, if GCS less than 8, intubate, we know that. However, if your GCS is decreasing by 2 or more rapidly, we'll talk about this in detail here in a second, but if I'm witnessing the GCS after a traumatic brain injury or closed head injury, if I'm watching and I see a decrease in the mentation of the patient to GCS points, then obviously intracranial pressure is going up, number one, and number two, or I've got an anoxic injury. So I need to be addressing that with oxygenation and possibly ventilation. So the key right there is to understand that this patient is not going to get better during transport. If I witness them losing 2 GCS points, that patient during transport is going to progress. There's very little we can do to stop that progression in field treatment as far as rotor wing. And if we happen to be in hospital and we're seeing this, there are some things that we could do that should indicate a clinical course. And some of the things that we talk about with the intubation is clinical course. So if this patient's deteriorating and I'm watching it, whether I'm in the hospital or in the field, then I should probably be anticipating the clinical course of the patient to worsen during transport. So my critical thinking skills tell me at this point, I should be thinking somewhere along the lines of, okay, if I don't intubate the patient now, am I going to have to do that in the rotor wing if they continue to deteriorate? And I just said that this patient is going to continue to deteriorate. If they're doing it in front of you, they're going to continue to deteriorate. Exponential growth. You've got a very finite area in the skull that is restricting where blood and or swelling can go. So it starts pushing on the actual brain tissue itself and starts pushing and causing a shift in the brain tissue because of the pressures. And you're starting to see that with the GCS changes, and it continues. So each little bit of increased pressure is going to exponentially increase the amount of shift as it occurs. So if I'm watching that occur, then the clinical course would be to go ahead and take that patient's airway, get definitive airway control, because that patient is going to continue to deteriorate. I'm going to end up intubating them anyway. And it's better to go ahead and intubate them when I've got the room and tools and lighting to do so than it is to get them in a rotor wing where I'm sitting right on top of them and I may have to manipulate them quite a bit to get them into a position to intubate that might increase intracranial pressure and be harmful to the patient during transport. Same thing in facility when I'm getting the report from the physician and or nursing staff. If I see the clinical course going toward airway control, it's better to go ahead and get airway control in that environment versus going out in the field, getting them in the ambulance, bouncing down the road, getting them in the aircraft where I've got limited room, limited space, and limited lighting. You're decreasing your chances of success. I'm not saying that you can't do it. I know there's some egos out there that are doing, I could intubate them, doesn't matter where they're at. That's good that you're that confident in your airway skills. The problem is that you don't know until you're finished whether or not you're going to be able to take care of it. And it's better to have all the tools and the lighting and the controlled environment to do that in than it is to take the patient into an ambulance or into the aircraft and try to do it there. And it's safer for the patient. And that's our goal, is patient safety. So that being said, that's one of the treatments. And then you want to maintain your CO2. If you've got signs of these things, and it states it specifically in the protocol, hemiparesis, unilateral blown pupil, witness GCS decrease of 2 or more, then your end-tidal CO2 must be maintained between 35 and 45 millimeters of mercury. If the patient's not in shock, elevate the patient's head, or if you're not in a position to elevate the patient's head, because they're on a spine board, you can still raise the bed underneath the spine board up 15 degrees. Be aware in the aircraft, specifically the rotor wing, there's a bulkhead there. You might have to lower them down to unload them, unless you want to put a knot on their head and then have to write a Baldwin safety on it. So if we know that they've got hemiparesis, unilateral blown pupil, and a witness GCS decrease of 2 or more, we need to at 30 millimeters of mercury. And that's because they're actively herniating at that time. So pharmacological interventions, if the systolic blood pressure is less than 100 millimeters of mercury, we want to initiate a dopamine infusion. This is to maintain the cerebral perfusion pressure. We need to get that changed in our protocol to a MAP of 90. That is actually the goal, is a MAP of 90, not 100 millimeters of mercury systolic. That's a good starting point, but mean arterial pressure is a much safer place to be for that. If your systolic blood pressure is greater than 180, we want to try to get that down to close to 160. So we're going to use nicardipine, 5 milligrams a minute, titrate up by 2.5 milligrams a minute, Q10 minutes to a target of 160. The other treatment that we can utilize is labetalol, and this is for systolic blood pressures greater than 200, because labetalol is going to bring it down. And then we can use the nicardipine. Be careful adding nicardipine too closely behind labetalol. You can have a profound blood pressure drop. Again, we don't want profound drops. We want to gradually decrease. Labetalol 10 milligrams Q5 minutes for a systolic pressure greater than 200 or a diastolic greater than 130, and avoid that precipitous drop. If you happen to be in a facility and they happen to have mannitol, 1 gram per kilogram over 15 to 30 minutes using a filtered IV set. This is with altered GCS and unequal pupils, of course. The mannitol is not indicative if CT results are negative for cerebral edema. And of course, don't give atropine to a patient that you're giving mannitol to. Some things that we do when we intubate to blunt, that of course is to ensure that we're not creating anoxia, is hyperoxygenate the patient prior to intubation, and then as well think about the things that you can do to blunt it. When turning the patient, keep the hips flexed less than 30 degrees. Typically, you want to keep the leg straight. If you flex their flex their hips, it actually increases intracranial pressure when you're turning the patient. The reason why is it increases thoracic pressure as you roll the patient. And increased thoracic pressure decreases venous return and would thereby increase intracranial pressure. Secure the endotracheal tube around the ears. You don't want to put any pressure on the jugulars. Our securing devices actually come just underneath the ears, so it should not. Our commercial devices. Keep stimulus to a minimum. Sedation and pain control. Look, most of these patients, because they're seizing and or posturing, they may require neuromuscular blocking agents. Fairly safe to say that that would be okay in these patients. The problem is that when we use NMBAs, the sedation and pain control isn't as good as typically. Field staff don't medicate enough with sedation and pain control for patients who have received a paralytic. It's well documented, and it's something you need to be aware of and know the time frames that you need to be repeating those medications, and repeat them throughout the transport. Till we get the protocol in place to hang the drips for these patients. The multiple dosing is the way to go, and it is absolutely imperative that you maintain that. It is imperative to maintain that sedation and pain control for that patient, as it is to keep their end-tidal CO2 at 30. And most field staff don't continue sedation and pain control on the time frames that's recommended. And use the time frames that are in your protocol for pain control. Indications for ICP monitoring: GCS less than 8, posturing, flexion or extension, bilateral, unilateral pupil dilation, CT scan showing edema or midline shift. If it's showing edema, that's when you're going to use the mannitol, if you get down to using mannitol, not just for bleeding, okay? Do your physical and neurological assessments prior to your neuromuscular blocking agent. If you don't, then you're at a loss on what the patient was at or what they're going to go to. What conditions are contraindicated for ICP monitoring? DIC in an awake patient. You don't want to drill a hole in somebody's head that's awake. And if they've got DIC, the bleeding's going to be profound. And you're going to be actually creating more of a problem than you are fixing by trying to put in monitoring. So those two items, if they're in DIC or they're awake, and when I say awake, they're conscious, alert, and oriented. And you absolutely want the patient to be still while the physician's trying to drill a hole in the brain. Types of ICP monitoring: subdural, interparenchymal, intraventricular, epidural, subarachnoid, and extracranial. And each one of these has different advantages and disadvantages, and most of these aren't as accurate as what we want, which is an absolute number. There is one that does give us an absolute number, but is very invasive. We're going to talk about these a little bit. Here's the different types. You got ventriculostomy, intraparenchymal, fiber optic catheter, epidural transducer, subdural catheter, and a subdural bolt. And let's talk about these. Subdural, of course, the catheter is positioned below the dura mater, used most frequently to drain a subdural hematoma, but can be hooked up to a fluid transducer, and you can get an ICP reading from it. Advantages are it reads from the subdural space. It's not quite as invasive as some of the others, and the disadvantages is you can't drain the CSF, which in some cases is imperative to decrease the pressure in the brain from the Monroe-Kelly doctrine. Accuracy and reliability over time is poor. This is the location and placement of that catheter. You can see that it slides in just underneath the skull into the dura mater and is placed there, and it can get kinked off pretty easy. Intraparenchymal catheter is positioned directly into brain tissue. Sensor can be fiber optic to transmit it to a Camino or Ventrix monitor. Sensor can be a microchip which correlates atmospheric pressure to ICP, then is transduced to a Codman monitor. Advantages: obtains reading from the brain tissue. Quick to insert, accurate, and reliable. The disadvantages: it can't drain the CSF either, requires a secondary machine, moderately to highly invasive. You're actually going into the brain tissue. It's very expensive, and it does destroy the brain tissue that it's going into. As you can see, they make insertion into the scalp, go through the scalp, through the skull, and actually go into the brain tissues. Very accurate though. And these require the Codman monitor most generally. ICP. Epidural. Catheter is inserted into the epidural space through a burr hole. And the advantage is the dura is not penetrated. Disadvantages, it's not directly measuring ICP. It's pretty indirect. It's not quite as accurate. And you're unable to drain the CSF. Intraventricular ICP monitoring. Catheter is placed directly into the ventricle, usually the right lateral ventricle. It's placed primarily in your head injured patients for hydrocephalus and also in hydrocephalus and brain tumors. Advantages, obtains readings from the ventricles. It is the most accurate. This is usually what they put in if they're dealing with severe head injuries. Can drain and measure CSF. Catheter is more flexible. It's pretty cheap. Highly invasive. Obstruction of fluid column may make it inaccurate. So you have to flush or let it drain and flush itself. Must maintain a fixed reference. So this goes into the scalp, through the skull, through and into the lateral ventricle. And of course, it's going through brain tissue to do that. These are the trajectories for insertion. The most common trajectory that I see is the burr hole from the occipital area in the back going through. Is the typical one that I see. Occasionally it'll be in the frontal aspect. System, Codman and Camino are the most common. Let's see, let me throw my notes here. Cover just about everything up to that point. Yeah. Preparation for insertion, if you happen to be in there when they're about to put one of these in. Actually, when I was in paramedic school, I was allowed to assist a neurologist in putting one of these in, putting a bolt in, and drilling through the skull was a totally different feeling than what I was expecting. And the tool was one that I'd used in shop, actually. It's a hand drill, and I got to hand drill through the occipital area, and the trajectory was towards the scapula, midclavicular area, jugular notch toward the scapula area, and drilled the hole, and it was just an odd feeling. Just thought I'd share that with you. You get, like most drills, when you're drilling through wood or anything else, you get to that point where it catches just a little bit and you know you're just about on the other side, and you turn 1/4 more turn so that you don't drill into the brain tissue. And it was a little nervous about it because here I am in paramedic school and this neurologist let me drill a hole in somebody's head. That was to say I was scared to death would be an understatement, especially in medic school. So your preparation, you're going to have CBC with platelet count, PT, and PTT for obvious reasons. All coagulopathies must be corrected prior to placement. Antibiotics, of course, prophylactically, that's the last thing you want, is to create meningitis by getting an infection in the brain. Position the patient supine with the head elevated, fold a towel while keeping midline, shaving prep aside, prepping test all monitors, and use sterile technique. Of course, most most of these procedures the neurologists have performed so often, it's almost ad nauseum to them. They just blah, 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 and do it. But anyway, level of transducer at the foramen of Monroe. It's the outer canthus of the eye, top of the ear, tragus of the ear. Apply betadine ointment at the catheter site, cover with sterile 2x2 and secure with foam tape. Document, 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 and let's talk about what you need to document. Pre and post neuro assessment, pupils GCS, what meds were given, and the dosage and the time, type of procedure or catheter placed, location of that catheter, opening pressures, the CPP, the CSF description, if you can see it, treatments ordered and procedures performed, the waveform, level of the transducer and bag, and the dressing in the head of bed position. The head of bed position and stuff really affect what the pressure readings are going to be. Ongoing assessment. Watch for CSF leakage, bloody drainage, no waveform after troubleshooting, catheter dislodgement, neural changes, photophobia, fever, nuchal rigidity, Brzezinski's sign, and Koenig sign. Now, I know you're sitting there and you're thinking, well, what in the world is Brzezinski, or who is he, and why does he have a sign? Why can't I have a sign named after me? Yeah, really. Brzezinski is neck flex, legs bend at the hips. So you flex the neck and the legs bend at the hips. That's Brzezinski's sign. Koenig sign is unable to straighten the knees when flexing the legs at the hips. So you pull up the legs to at the hip joint, and the legs won't straighten. They stay bent. ICP waveforms. P1 there is your percussive waveform, reflects arterial pressure. P2 is your tidal wave. That's variable and indicates your cerebral compliance. And it ends on the dichrotic notch, which everybody's familiar with. The dichrotic notch in critical care medicine is one that is talked about a lot in arterial waveforms. And it is mimicked here because it is the venous side. Dichrotic wave reflects venous pressure, follows dichrotic notch on arterial waveform. If P2 is higher than P1, intracranial hypertension is occurring with decreased compliance. So P2 higher than P1. If you look on there, this one's setting about 18 millimeters of mercury. And if P2 was at 20, that would be higher than P1, and you have intracranial hypertension, okay? Waveform types, A waves, plateau waves, not good. Signifies patient has cerebral hypoxia, ischemia, and possible areas of infarction. ICP is usually greater than 50 millimeters of mercury at this point. Remember, we said that 0 to 10 is about normal. Some will stretch it to 0 to 15, 15 being on the higher end of the scale. Anything greater than 20 is bad. Anything greater than 40 is super bad. So you're getting hypoxia, ischemia, and infarction of the brain at that point. Okay. B waves, not significant, usually associated with respiration. And ICP transiently increases to 20 to 50. That's not as concerning as the A waves. C waves are normal wave related systemic changes in arterial pressure, ICP less than 20. That is an A wave form. You see the plateau there, it's well high, it's nice and flat. That indicates massive pressure. And of course, then on the scale, it's also doing it. It's showing on this scale about 79 to 80. Some conditions that may reflect those abnormal waveforms: increased mean intracranial pressure, removal of intracranial pressure, increased CSF can actually do it. when I talk about increased mean intracranial pressure, I'm talking about P2 greater than P1 and may even bury P1. Extreme arterial hypertension, you're going to see P1 amplitude increases, not much P2. As extreme arterial hypotension occurs, you see mean ICP decreases, amplitude decreases, especially P1. Cerebral vasospasm, decrease in all components of the waveform. Severe hypercapnia or hypoxia, increased ICP waveform, amplitude, and rounding. You'll see a rounding of it. Jugular compression, you get a mean ICP increase. Remember I said to keep the jugular veins from being compressed, you want to make sure that you don't have your intratracheal tube going over the jugulars. Your securing device, you want to make sure it's up closer to the jawline and lower tragus of the ear. And you want to keep the head in the midline position. You don't want to have them turning side to side. Hyperventilation, or let me go back. Bilateral jugular vein compression, you would have P2 and P3 increases. So your dicrotic notch will increase as well because it's venous compression. And your dicrotic notch is the beginning of the venous side. So hyperventilation, no change in P1, P2, and P3. It will change. This is the measurement of the boxes, and the paper, monitor paper, of course, is made up of small and large boxes, just like your 12 lead. Horizontal axis is meters of mercury instead of electrical current, like your 12 lead. With one small box is 0.4. 5 small boxes equals one large box of 0.2 seconds. And 5 large boxes is 1 second. That small box, that should equal 0.04. And there it is. And what is that reading? It's right at 20. You want to check your system to troubleshoot it. You want to check your system for blood clots, tissue, or air in the tubing or transducer. You need to zero it and recalibrate. Check the scale for accuracy. Check filter for wetness. Check stopcocks that they're are in the right position. A lot of times the 3-way stopcocks get messed up, and it's obvious when it starts messing with your waveform. Check catheter patency by lowering the bag and look for drainage. Observe ICP response when the jugular veins are compressed. You should see a rise. If not, catheter may be clogged. This is probably the easiest check. You don't want to choke your patient though. Just do one side or the other. Observe ICP response when jugular veins are compressed. Should see that rise again. Potential complications. Everything we do to a patient has a potential complication. Over drainage, patient sits up quickly. We shouldn't have that in the field. Head a bit higher than the drainage bag. The drainage system is left open. Under drainage, you got a clogged catheter. You may have some purulent drainage. This is for the long-term patient or some blood clots. Drainage bag is not leveled properly. Of course, if they get meningitis or ventriculitis. If you look at this, it's going to be sitting there, and if you look at the x-ray that the doctor is looking at, you can tell that he's giving him some advice that he might need to use that right side of his brain a little more. Some scans. This one's normal. You can see the ventricles there in the middle. It has a little butterfly pattern. You can see some outline of the actual brain tissue. In good white, there is the bone. Typically white is bone or blood, and you can tell by looking at this that this patient has a pretty significant bleed. It's an epidural bleed, obvious compression. You see the ventricles have been collapsed, and they're trying to drain to allow that to occur. Might be a little bit of bleeding on this on the right side of your picture. Let's see, or not a little bit, quite a bit of bleeding on the right side of the picture. You can see the outline of the skull itself, and you can see the differentiation on that right side between the skull itself and the brain tissue and how much concave it's gone into the head. This patient would be having altered mentation and GCS changes. This you can see if you compare left to right. I can see the right ventricle very, very well. I'm not seeing the left ventricle very well. And if you look at where the arrows are pointing, you see some white in that area. That's contusion and swelling in that area. That's a cerebral contusion. This one is a subdural bleed, and you can see the obvious shift. The ventricles are very compressed on the left, and I can see part of the ventricle on the right, and see a little bleeding in the ventricle as well. This is the effect of an uncle, and this is the bad uncle, the guy you don't want around at your Thanksgiving or Christmas holiday. Just a little joke. The uncle herniation is distortion of the midbrain due to the herniation of the medial temporal lobe structures, and compresses on the midbrain and also down through the foramen magnum. And that's the end of the presentation. I hope you enjoyed it. Review your protocol. Be sure to review not only your intracranial pressure protocol, but your pain management protocol, your RSI protocol, and your medications for hypertension and hypotension in your protocol to be able to treat these patients effectively and safely. I appreciate your time. I hope you garnered something from this lecture. If you have any complaints, concerns, or additions to, please contact me at jreal@apollomedflight.com. I hope you have a blessed day.